evening, everyone. I'm really excited to see you here, and I am even more excited to be here up on stage and helping bring this program to the Columbus area. I'm Laura Kolaczkowski, and I am from, woohoo, thanks, Dr. B. Nice shout out. He might be even able to spell my name, but we'll test him later. I'm from the Beaver Creek area, and I do have MS. I have a particular fondness for doing things with other people that have MS because I think we don't get out enough. And this is the start of a new series here in Columbus that I'm really excited for Ohio Health. I'd like to just give them a shout out because this is a great program format. We have worked closely with the person who's coordinated this program and put the details together, and that's Stuart Schlossman from MS Views and News. And at this point, I'd like to get Stuart up here because he has a few special people from the area to introduce. Stuart. Stuart.
No, Stuart Schlossman.
I did. Did I say his last name? I did.
There you go. Thank you.
Hi,
everybody. How are you all doing? Forget my y'all, but I've been spending a lot of time down in Alabama and Georgia lately. We do a lot of programs down that way, so I just have a habit of saying this these days, and it makes them feel great, makes me feel a little bit less when I'm elsewhere, but I just wanted to say that to you all. MS Views and News right now is doing something different. We're partnering with another organization to do a series of programs, and I'd like to thank first, and I hope everybody does too, Ohio Health, all right? Because Ohio Health wants you all, not just as the patients, but caregivers. We want you all to learn. They know the value of our programs. We want everybody to know what MS is and how you can live better having MS. Just because you have this disease doesn't mean life is ending for you, all right? You could get out there and do, all right? And just do and do and do, all right? So you see the video cameras, right? This is no big deal for me to be standing here in front of these things. We have over 200 videos on our YouTube channel, all about multiple sclerosis. So if you want to know anything and everything you want to know about MS, you can find our YouTube channel, which is the MS Views and News Learning Channel on YouTube. You go to our website, or you just go to youtube.com/MS Views and News, and you can go there and go scrolling through all the different videos there. Again, there's over 200 videos about anything and everything about MS. And you can even see a guy named Aaron Boster, that did this for us in September of last year down in Cincinnati. I just got to tell you something funny real quick about that program. We're not allowed to take video of anybody in this room, all right? It's only the people that are up here. But Dr. Boster thought it would be great, like he always does, to just get off the stage and run around the audience. Well, the guys that were shooting the video just spontaneously went to follow him, not realizing that they're getting everybody's faces too. Big no-no, Dr. Boster.
Sorry.
All right. So anyway, that was just something funny that happened. Now, really quick, my name is Stuart Schlossman, as Laura said, and I too have multiple sclerosis. And it was back when I was diagnosed in the 90s after 20 plus years, 30 plus years of not knowing what was wrong. We found out, finally got a diagnosis, and I learned, though, that the healthcare industry, though, did not want to or didn't have the time to tell me what was going on with me. So being internet savvy, I got up on the internet, started finding information for myself, for a small support group, and that small support group has turned into now over 25,000 in our database, and our information is reaching people every other week in our newsletter to over 90 countries. So that's the information that we're providing. We're doing this for a reason, because we know people need to be educated. For some of our goals for 2017 is to get out to outside the metropolitan areas and get to the underserved areas of the United States. We're presently doing programs in 15 states. By the end of this year, we'll be in 17 states, and hopefully next year we'll be in 20 plus states. So I don't want to go on and on and on because we don't have enough time for this tonight. All right. Something that we do at every one of our meetings, we ask support group leaders to come up and speak for 90 seconds about their group. And I think we have one person here tonight that's a support group leader. Her name is Regina. She's all the way in the back. And nobody else came to us in advance. Well, you got to go outside and sign a document really quick if that's what you want to do, all right? And just see Jill. She's at the front table, all right? we're going to ask Regina to come up. She's got 90 seconds to speak about her group, and then Laura will be up after the other person, all right? Thank you. Is this good for you?
Thank you. That's fine. Hello, everybody. Hi. My name's Regina O'Neill, and I, along with Rachel Bibb, facilitate the Columbus East Side Self-Help Group of the MS Society. We meet every second Tuesday of the month at the MCL cafeteria at 5240 East Main Street. We have a lot of people that participate. Rachel always has nice programs for us to experience and to learn from. Every month we have different people from the community come in and talk to us about different needs and about different things that we as the MS patients could benefit from. If you have any questions, you can call myself or Rachel. That's Rachel Bibb and Regina O'Neill. My number is 614-863-1911, and Rachel's is 614-860-1968. If you have any questions, just give me a shout out, and I'd be happy to answer anything that I can. Okay? Thank you.
Now, just so you know, the benefit of what she just said, calling out her number, you didn't even have to write it down, because this is going to be published within 2 weeks, all right? So everything about this program that you don't remember, you could go back and watch again, or you could turn on family and friends to it as well, all right? And let them see what's going on and what the doctors, what the clinicians are speaking about here today, which will greatly benefit you. And you could get Regina's number from there too. Now we're going to introduce Jenny.
Hi, I'm kind of impromptu here. My name is Jenny Savitskas, and I do have a support and friendship and getting out there kind of group. We meet every third Sunday of the month right now, usually in the afternoon. We are affiliated with MSF, based in Florida. You can find out about us through the website www.meetup.com, and then just look for the Columbus MS Friends and Support Group, I think we're called. So again, we generally have been meeting more toward the north of Columbus, but in the Columbus area, at least once a month. So nice to see you all. I know a few of you, and Ohio Health is awesome, so thank you all.
Thanks to Jenny and Regina both. What community leaders do continues to amaze me, because that's really an important part of working with your MS. And I am ready, Bill, if you'll pull up my presentation. Which is good, because I think you all saw this slide a whole lot while you were sitting there. I wanted to talk to you because you all got a choice, okay? We have MS, and what happens, you say, oh, MS, everything's over. Let me stick my head in the sand and not do a thing. I want to tell you right now, there is a lot that you can do about your MS. Everybody see this cartoon? It says, what are you doing? Life has overwhelmed me, so I've shoved my head into the sand. Well, why would you do that? Because ignoring reality is the next best thing to changing it. I say we can change this reality with what we're doing. What I'm going to challenge you tonight to do is I really want you to get your head out of the sand and get in the game, because there are a number of things that we can do on our own to make life with MS better. The first thing I want to talk about is you can assert control over some factors. Your doctors can't do this for you. Your partners can't do this for you. Your kids certainly can't do it for you. And I'll confess, I'm doing a little bit of do as I say and not as I do, because I'm not good at all these things either. But you need to be compliant with your therapy. If you smoke, I'll tell you right now, I smoked for 35 years. Quit cold turkey, it's not fun. But I quit because I also had a heart attack, so that's a different slide set. If you want to quit smoking, see your providers. They'll help you. They will give you the tools to do that. Same with stress. Stress is horrible for MS. And I'll tell you, I'm an example of that because I'm standing here, I have shingles. I have shingles from my navel to my spine, and it hurts. And that comes from stress. Lack of exercise, you know, who in this room really honestly exercises regularly? You know, and we know exercise helps. Weight, your sleep patterns, do you get a good night's sleep? Dr. Boster can tell you all about sleep hygiene and how to get a good night's sleep. Same with diet. We don't know. We know there's no diet that's going to cure MS, but we know there's a diet that's healthy for us, that gets down our blood pressure, that helps our cholesterol, that impacts all sorts of things that play into our MS. And the final piece of that is isolation. And all of you right now are doing something to break that isolation because it's really easy to sit at home and do nothing and feel like I'm in this alone, and that's the worst thing you can do. So I want you to assert control over your MS. Next thing, I want you to prepare for your visits. All of you should be doing this. When you're ready to go to the doctor, you should make a list of all the things you want to talk to the doctor about. I mean, everything. Make that list long. It should be. Down to what should I eat tomorrow for breakfast? And then look at that list and take everything off of it except your 3 most important items. Because your providers only have a little bit of time with you. The sad truth of our healthcare system is they don't have leisure time with us. They can't sit and go through an entire list. So pinpoint those 3 items that are the most important to you and be sure to go over those. Take notes while you're doing it. We're lucky Ohio Health uses my chart, so when we leave, I get a printout of my notes, but it's really important. Take notes. And then finally, I think the most important thing here is if you don't agree with your doctor, speak up. This is your MS. People don't understand. This is your body. This is your life. If you have questions about your treatment plan, you disagree about recommendations, they're not mind readers. You got to talk to them. MS Views and News has a wonderful communication tool online. It was a link that came in your email. You can go online and you can actually type into those fields and get it all printed out. If you're nervous about talking to your doctor, like I don't know how to talk to him about some of these things, print it out and slide it across the exam table and say, here, look at this. So, you know, that's a good way to break the ice. So use that tool because it's a great tool. Education. You're here tonight to learn more. This is the MS education program. All of us are products probably of Schoolhouse Rock. Knowledge is power. We all agree. The more you learn, the more you have power, the more you learn about MS, the more you're going to take control. And that's what we want to do is take control. Used to be, you know, like back in the 60s and 70s, we got our information in these little glossy brochures. Here, take this home and read it. Then it got to be videos and multimedia, and we'd laugh at the hokey videos. They were horrible, but they were entertaining. Then we got the electronic information from the internet, right? And now we can get information about MS from so many different sources. It's amazing. You can learn anything and everything you want to know, and it may be right or it may be wrong. That's the key part. And I don't know where we're going with information in the future and where we're going to get it from, but I wanted to note at the bottom of this information, when I put this together, information and how we've gathered it has changed over the decades, but the one constant here that hasn't changed is your doctors, your nurses, your therapists, the people that interact with us from our medical team. They're always there for information. Same with advocacy groups like the MS Views News and the MS Society. The final piece of what I want to tell you about is this is ultimately the ultimate empowerment tool that I can think of, is taking control of MS research. I am fortunate to serve as the lead patient representative for iConquer MS. We are a national movement. We are a database right now. It has almost 3,000 people from the US and 22 different countries involved. I challenge each one and every one of you to help me move this forward, be part of this big picture, and find answers about MS. It is patient-led. Over the majority of the people who are on this organization have MS. They understand what we go through. It is patient-directed. We decide what research we're going to look at. And we get those research ideas from our community online. There's the opportunity to put in your research questions. Just a real quick show of hands. How many of you in this room have ever had a researcher say, what do you want to know about MS? Yeah, exactly. They've never asked before. And we have questions, we have ideas, we have things we want to learn. And this is our vehicle to do it. So please, take a note of that address. I have M&Ms still. There was a little thing on the top of the M&Ms that has the address on it. Join me through I Conquer MS. If you've got questions about it, talk to Dr. Boster, talk to Dr. Nicholas. They're both familiar with it too and endorse what we're doing. So that's it from me. I know you're saying, Laura, we didn't come to hear you. But hopefully that wasn't too painful, because I really want you to get the most out of tonight's program. We have a lot to jam in here. We have 4 speakers, 4 topics we're covering. We're going to do the first 2, and then we'll do a question and answer session afterwards, and then we'll do the next 2 speakers and follow up with questions and answers. The facilities are down the hall. If you need to use them, I know I probably will. Just go out quietly. And I hope while they're talking, you all have paper, pencil, something. Take notes. Write down your questions and be prepared to ask them. We would ask that the questions that you ask tonight not be specific to you. Don't say, oh, gee, this morning I took 3 of XYZ pill and I don't feel so good, so what do you think I should do now? What we want are general questions, things that everyone in the room will learn from and benefit from. So please think of that, but we do want your questions. A lot of you picked up that nice blue notebook, so write your questions right in there, because you got great experts in the room who are going to take care of that for you. So to begin with, our program, I am going to introduce Ms. Sarah Grimm. If you don't know Sarah, you should, because she's a very important part of this MS team at Ohio Health. Sarah's a licensed social worker. Come on up, Sarah. She specializes in MS. The things that aren't clinical, clinical, that's that medical stuff that's got to get taken care of. I got a broken bone, I need a prescription, I need whatever, take my temperature. She's not going to do that. But if you say, gee, I need help finding assistance for a new wheelchair, I'm too hot and I need equipment or whatever, Sarah's going to be the person to go to. She did my disability paperwork. So with that said, I am going to turn this over to Sarah, please.
Thank you.
Yeah, I don't. You good? She wants to make sure I don't fall off the stage. Me too.
You got it?
Yep.
Good evening. I'm Sarah Grimm. I recognize a lot of people here, so that's very exciting. I'm actually not going to take up too much time. I just want to say just a couple things, and I'm going to piggyback on some of the things that Laura said. In my experience, the number one recommendation I have for folks living with MS, whether they're newly diagnosed or have been living with it for a while, is to get involved. I have had a great honor to run several support groups through the Ohio Health Clinic, and I cannot express how enjoyable it is to see folks living with MS connect with other folks living with MS. So coming here for education, going to the support groups that are here in town. There are also some really good groups in Lancaster and Mansfield, all around Ohio. So really, I think my only main point here today is to try to get involved and get connected with folks who can understand what's going on, who can help you problem solve, who can help you find resources. Just social connection is really, really important when you're living with MS. If you do attend our clinic at Ohio Health and you haven't met me before, please, next time you're there, ask to talk to me. I'd love to say hello, and we can talk about resources, and we can talk about our support groups that we do at Ohio Health, and I'd love to say hi to you. If you do know me, still come and see me if it's been a little while. And just want to encourage you all just to continue to participate in programs like this and programs through the National MS Society, and stay involved and stay connected. That's all I have for tonight. Thank you.
Thank you. Before I introduce our next speaker, I just have a quick couple of other things. Number one, as you know, the cameras are set up here. Anybody on that side of the room, if you need to exit to use the lavatory or just to go outside and talk, please only use that door or that door. And on this side of the room, please only use this door. So that way you're not walking in front. We don't have to stop everything from what's happening here. Okay? And then there was something else. What was the other thing, Laura? I already forgot. Oh, yeah. So they're going to be serving food in a moment, okay? For those that are wearing a green wristband, we know you're vegetarian. Please hold it up for the server to see so they serve you the right food, all right? And if you're gluten-free, you're wearing a pink wristband, show them that so we make sure not to give you bread or anything like that, okay? All right, so next up, we have Dr. Nicholas. Did I say that right? Great. And she looks, I love that color she's wearing. That's great. So come on up. We'd love to have you here. Thank you.
So Stuart and I plan to match today. We both like purple. Thank you guys all so much for coming tonight. I'm really excited to be up here to speak with you about a topic that's really near and dear to my heart, and that's women's issues in MS. I want to rest assured, ladies, men have lots of issues too. We all know. But tonight, we're going to just be talking about the women. I brought my silly sunglasses up here with me. My daughter accidentally scratched my eye last night. She's a baby. So if I start blinking a lot, it's not because I'm winking at you and being really creepy, but it's just because I'm having a little bit of trouble with my eye. So we'll go ahead and get started here. There'll be plenty of time at the end for questions. So you guys are well aware of this. You know a lot about MS. You've been dealing with it, I'm sure, for quite some time. But just to kind of step back and review, MS is a chronic, progressive, inflammatory disease that affects the central nervous system. So it affects our brain and our spinal cord. And it's very important that when we think about MS, that we realize that we have to take it very seriously early on. It's the leading cause of non-traumatic disability in young adults. And so that's why we're so fortunate to have such great treatments to be able to stop the progression of the disease and treat people early so that they can do well and live well lifelong. Currently, we're not entirely clear on what exactly causes MS to be set off. We know that it's part genetic, but it's largely environmental. So there are lots of risk factors that people are exposed to that make it many more times likely that they would develop MS. A couple of these I'm sure you're very well aware of are low levels of vitamin D. Interestingly, recently there's been a lot of interest in high salt diet. Certainly women are much more likely to be affected than men. We know that the predominance is about 3 to 1. And so it's very interesting. We're going to talk a little bit about hormones in MS and why that may be. But I think that it's really important to point out that you're not alone. If you're suffering from MS, MS is very, very common, and I think a lot of people don't realize it because when you're walking around with MS, they don't always see signs of the disease. And so a lot of the disease symptoms are experienced silently by the person. But I think it's important to know that about 1 in every 750 folks in the US suffers from MS, so that's why we're so passionate about getting out there and educating all of you to empower yourselves to do well. So again, you can see that it's incredibly common. The typical age of onset is about 30, and again, women are much more likely to be affected by MS than men. I think that it's very important to educate people early about the specific factors related to your disease. I say this particularly in women because the majority of our MS disease-modifying therapies, in fact, all of them, are not recommended for use during attempts at conception and pregnancy and breastfeeding. Now that's with a caveat, and I'll talk to you a little bit about that as we go along, but it's not fun to have surprises. Now some of you that have heard me talk before may have heard this story. It wasn't funny at the time, but it's a little bit funny to me and one of my patients now. I remember I was taking care of her. She had pretty aggressive MS, was a mom of several children already, and she came in to see me, and she said, "Dr. Nicholas, I have something I have to tell you." Well, I looked at her and I could already see her pretty protuberant abdomen, and I said, "You're pregnant." And she had been on an MS therapy that wasn't such a good idea to be on when you're pregnant. And I said, "Okay, let's see what we can do about this." So, this patient was evaluated by OB and was very, very far along in their pregnancy, actually ready to deliver within a couple of weeks. So that actually happens. It's not just on TV. That being said, when I came over to Ohio Health and that patient followed me, they came into the room and I was 3 months pregnant and nobody else knew it. And she said, Dr. Nicholas, you're pregnant. So a lot of times when you're the person, you may not be paying attention, you may think it's not going to happen to me, but with MS disease-modifying therapies, it is very important to not become pregnant on them. And so it's not to say that you shouldn't become pregnant. We absolutely want to support that in women, but if you are planning to have a child and you're on a therapy, it's important that you talk to your doctor and you do it in a planful way. We'll talk a little bit about the timing of that and what's important to think about in the setting of MS. There is a therapy that I do sometimes use off-label, and when I say off-label, that means that the US FDA doesn't recommend it. They only recommend things for use in pregnancy if it's been studied in pregnant women. Well, as you can imagine, there's no ethical study that's going to be done that says that an MS disease-modifying therapy is safe because it was studied in pregnant women. That being said, there's a therapy called glatiramer acetate, or Copaxone, and there's been quite a bit of safety data on that, and that's something that I use very comfortably in women who are attempting to conceive or are pregnant and breastfeeding, because there's never been any evidence that it causes an increased risk of abortion or harm. So that's something that if you're thinking about it, I encourage you to talk to your neurologist about it. And certainly on all other forms of MS disease-modifying therapy, contraception is recommended. So if you look back in MS history, it wasn't always recommended that women with MS get pregnant. Doctors actually said, this will make you worse, do not get pregnant, it is a horrible idea. Well, they couldn't have been further from the truth. We actually found out that pregnancy in MS is protective. So if you could just be pregnant for the entire time of your reproductive years, you would do really, really well from your MS. But I don't know about you, I didn't feel so hot when I was pregnant. I didn't like it so much. It was nice afterwards. But some people say they like it. That being said, what we found was it wasn't pregnancy that was the problem, it was the first trimester afterwards. So that's right, ladies, 4 trimesters. They're not 3, they're 4. So it's that first 3 months after that's high risk. And so there are factors that we look at. One of the concerns is how active has your MS disease course been in the year prior to pregnancy? And if you've been having relapses or new disease activity on MRI, in the past year, before you're thinking about conceiving, that's probably not the best time to try to get pregnant, because that predicts that you're going to be much more likely to have a relapse during pregnancy and even in the 3 months postpartum. And so that's something that when I have young women come in who say they're thinking about it, we try to get their disease under good control and then wait. I think it's important to know that MS doesn't impair fertility. A lot of women with MS think about, should I use a fertility treatment? I'm going to talk to you a little bit about that in a minute. And it's not high risk. You know, sometimes people get nervous and they say, I have MS, should I be seeing a high-risk specialist? Unless you have another reason to make you high risk, you are not high risk. And the best news of all is that there's no contraindication to getting an epidural. As silly as it sounds, they used to believe that getting an epidural for that pain medication during delivery would increase your disease activity. And so when I first came to Ohio State, and I was actually a fellow, and I was working with Dr. Boster, he would always tell women this, and I thought, oh my goodness, that's silly. What anesthesiologist would think this? But they actually used to. So all of my patients moving forward, I've always had them take my note and put it in their bag when they go to the hospital to deliver, so that they're not deprived of pain relief. It's also important to think about risk. When you're thinking about whether or not you want to have kids, it's understandable that you might be concerned, could I pass this disease on to my children? We would never not recommend that a woman with MS get pregnant just because she has MS or just because her spouse has MS, because that risk of passing it on to your child is incredibly low. It's about 2 to 3% chance increase from the rest of the population. So that just goes to show you that there is a lot of environmental factors playing a role rather than just your genes. And certainly in siblings, there's a slightly higher risk. If your brother has MS, you have about a 3 to 5% chance of developing it yourself. But if both parents are affected, that risk certainly jumps up to about 30%. And certainly offspring, 2 to 3%. So this is a very simplified version of hormones throughout the female life cycle. So interestingly, if you look over here on the slide, you can see that estrogen and progesterone levels rise along this y-axis here, and across here, we've got puberty, pregnancy, postpartum, and menopause. Here, prior to the onset of puberty, both boys and girls, they have equal incidence of MS. So MS can onset in childhood. It's about 5% of multiple sclerosis, but it's equal, and that's because we haven't had this differentiation with sex hormones. As we look, we see that adults with MS, it's more common in women, and these are with menstrual cycles that we have these subtle rises in estrogen and progesterone and drops. But then when you see pregnancy, we have this sharp increase. And we believe that those hormones, estrogen and progesterone, as they rise, they're protective against disease activity, protective against relapses in MS. But then when they drop, we unfortunately see that those relapses recur, and that's a very high-risk period in those first 3 months postpartum. So there are certain things that can be done based on someone's history to try to further lower that risk. And then after menopause, we often find that women with MS report that their symptoms have worsened, and that they have some worsening in physical disability. This has been proven in cohort studies and actually in several surveys of MS patients. And I think this is the next step of really where a lot of research needs to be done in women with MS. We don't have a lot of information about it. Sexual dysfunction, this goes for both men and women. It's a major problem in MS, and it's something that people are often embarrassed to talk about. I think it's important that if you have these issues, please bring them up in clinic. There are lots of causes. It may not just be your MS. Certainly if somebody is suffering from depression and anxiety, that can play a huge role in decreasing libido. If you've had prior inflammation in your spinal cord or transverse myelitis, you might have significant decreased sensation in the down theres, and that doesn't feel so good, and maybe you're not as interested. But there are lots of things that we can do to help, and lots of treatments, and so please ask us in clinic. What about the medical management of MS while attempting to conceive? Well, I alluded to this earlier. Here's a simplification of the MS disease-modifying therapies. These are all based on generic names that are available. And the FDA actually used to categorize every medication as a category. The lower the category, meaning the further the letter is from A, the worse the medication is for being on it during pregnancy. So category X is a medication called teriflunomide or Aubagio, and that's absolutely contraindicated in men or women who are planning to conceive. It's actually even excreted in the semen. It's something that patients have to be off for a period of 2 years, or you have to undergo something called a rapid elimination procedure with activated charcoal or a medication called cholestyramine. It's nice that we have that available, but it's not so pretty to go through. That's a medication that I avoid in women of childbearing age and men. We look here in category B, glatiramer acetate. That's the one that I mentioned to you. That's really the safest therapy that we have available that we can use in women who are planning to conceive or who are pregnant. The other therapies would not be recommended. These are interferons, fingolimod, natalizumab, Tecfidera, Lemtrada, mitoxantrone. Again, there's specific ins and outs to each of these and how long somebody needs to be off, but if you speak to your doctor in advance, we could plan for that. And again, this is just a review of the data on glatiramer acetate or Copaxone being safe, and that basically in long-term studies, there's been no difference than what is seen in the normal population for a given age. We talked about how MS doesn't impair fertility, and overall there's really no evidence that the MS disease-modifying therapies impair fertility, but that's with the caveat that sometimes we use other types of chemotherapies off-label in MS. Those certainly could impair fertility. Sometimes there has been some evidence that steroids may also impair that. Again, fortunately in MS we're using steroids for a very brief course of time for treatment of relapse. What about fertility treatments? This is something that there hasn't been a lot of research on, but the research that we have is concerning. So a lot of people nowadays are talking about fertility treatments. So what about in vitro fertilization or taking treatments to make it more likely that you'll ovulate? Now, there's a study showing that women with MS are much more likely to engage in using these treatments. And I've actually had lots of patients come into clinic and say, I know I'm going to go off my disease-modifying therapy. I'm really nervous. I want to make sure that I can conceive as fast as possible so that I can go ahead and get pregnant, for one, because I want to be, and for two, because I don't want to be off therapy and get worse and have relapses. this isn't really shown to be a good idea at this point in time. Again, we need lots more studies, but all of these studies show that if you go through assisted reproductive technology with any of these therapies, that you actually increase your risk of having an MS attack if it's unsuccessful. And I think that goes back to looking at what we saw with the hormone levels, where we talked about estrogen and progesterone. If you think about pregnancy, when those levels drop really quick, that's when we have that high risk period of a relapse. And that's the same idea here with some of these treatments. So it's something I encourage you to talk about with your doctor. This is one of my favorite studies. This was called the PRIM study in MS, and it was a long-term study of multiple pregnancies, over 200 pregnancies in women with MS. And what happens? What do we see as far as relapses? Well, let me walk you through this here. So if we look over here in this first white area, this is the year prior to pregnancy. Each marker here is a 3-month period. This gray bar very clearly here is pregnancy, and then this period is after pregnancy. This was the follow-up to the PRIM study, so 2 years of data following pregnancy. And basically what it showed is if we have the overall average relapse rate in the year prior, and then we look at pregnancy, we see that that successively decreases down. So in that 3rd trimester, there's the lowest risk of having a relapse, but then in that 1st trimester postpartum, after delivery, that's where relapses peak, and then it travels back down to the prior range. How do we treat relapses? Are we able to treat them in pregnancy? Well, we can. We really try to judge it and see how badly has it affected the woman. If it's something that's kind of minor, we'd probably try to avoid using steroids. If it's severe, certainly we would want to offer them. Generally, we talk with our OBGYNs, and they're in favor of treating if it's in the 2nd or 3rd trimester. In the 1st trimester, we have to think about it. The risk would be a slight increased risk of cleft palate. There are different steroid preparations that are more helpful or that are less harmful than others because they don't cross the placenta, and that would be Solumedrol, which if you've ever had an MS relapse and treated with IV steroids, that's the form, and then also prednisone. Decadron would be less favorable because more of that crosses into the placenta. IVIG is also something that we can use. We don't use it commonly in the setting of MS relapses, but that's been shown to be pretty safe in pregnancy. Don't worry, I'm not going to nerd out too much on these weird figures here. I see people maybe starting to fall asleep. I just like this picture because basically what it shows is if you have MS and you become pregnant after the onset of MS, you do better. So what this is saying is, how well does somebody do? So as we go here, if you go further down on this scale, that means that your physical functioning is worsening. When we look at these 2 lines here, these are women who had children before and after MS onset and had children after MS onset. These folks over here were women who either never had kids or were pregnant before they got MS. What we see is that it's actually favorable if you have kids. And so we think that even though there's that increased risk in that 1st trimester postpartum, it is favorable to have had pregnancy. And so that's really neat, and I like to show that to my women patients who are considering it. I just like to put cute pictures of babies in. So what about breastfeeding? Well, there's been a lot of controversy over this, and a lot of MS specialists have argued quite a bit, and they say, oh, breastfeeding, it's not harmful, but we don't think it's helpful. The problem is that a lot of studies have looked at women collectively who breastfed in terms of whether they only breastfed their children to any degree versus if all they did was breastfeed. So for instance, many women, due to time constraints or working, may consider breastfeeding but also supplementing with formula. That's a pretty normal thing, but we find that that alters the hormone levels. And so what we've seen as being protective in MS is women who breastfeed exclusively. We think that has some benefit at preventing that major drop in the estrogen and progesterone levels, and again, allows for some recurrence of the disease activity. But needless to say, the only point I'm trying to make here is that if a woman wants to breastfeed and she has MS, that we can monitor her carefully in most cases, and she can do so. However, if someone is breaking through and having more disease activity, we may need to consider stopping that and starting an MS disease-modifying therapy earlier. This is another big nerd study that basically shows multiple studies, and if you see a dot or a line here on this side of the bar versus this side, This side shows studies that favored breastfeeding in terms of preventing or decreasing risk of relapses, and so numerous studies have shown benefit. Again, this is another study showing lower risk of relapse in women who breastfed versus those who didn't. And what about parenting? I think it's important to think about the end game here. So certainly pregnancy is a hard thing to get through, but parenting is much longer. I think it's a wonderful thing. I'm sure many of you are parents, but I think it's also important to think about in advance, who's your support system? If you have kids currently, what are you going to do if you're having problems from your MS? Make sure that you reach out to friends and family. They want to help you. If you feel like you don't have support, reach out to us. Reach out to Sarah Grimm. She's magical and she can fix everything. She's going to kill me later for saying that. There's a really neat newsletter made by the National MS Society. It's called Keep Smilin'. That's something that your kids could get and you could sign them up for. It's a very wonderful newsletter for them to get. And then also there's Camp Connect in Columbus. Anybody who has children or if you have grandchildren and you're affected by MS, they're invited to attend every year and they do lots of fun events and we often get to go out and speak to them. This year one of our nurse practitioners is going to be present. Hot flashes, the best treatment for them is standing in front of a fan just like this. Just like hot flashes in menopause. In MS, we know that heat sensitivity is a major problem. It causes an increase of our MS symptoms. So menopause can certainly cause worsening of our symptoms. We have a lot more research that needs to be done to better understand this. And I'm going to go ahead and move forward because I think Stuart's going to pull the plug on me here. So living with MS isn't easy, but it's important that you share with us, with your clinicians, with your physical therapist, with your social worker, what we can do to make your life better. Please let us know if there's something that's bothering you that we haven't talked about when you're in clinic, and certainly reach out to your support systems. I think it's wonderful that all of you came out tonight. We want you to continue to fight back. If you have relapsing MS, take your disease-modifying therapy. If there's something that's blocking you from being able to take it, please let us know. Eat right, exercise, and get sleep. And please reach out for help when needed. I'm happy to answer any questions that you guys have.
All right, so that being said, first, congratulations and thank you. We are going to do this a little bit differently, all right? So Sarah, right there, Sarah, she's going to go around to the tables on this side of the room, okay? And we're going to do questions 1 and 1, 1 and 1, all right? We can only ask that whoever has a question that you can only do one at a time. Let's go through the room of who has questions. We can only do this for about 15, 20 minutes, all right? And then if we have time, we'll get back to you for a second question. Please know that we got to put this microphone in front of your mouth, all right? Please know that we don't want you to kiss it or lick it because the ones coming up next to you do not want to know that you were just doing that, all right? But please know that we do need to do this because we are video recording and we need to let everybody that's going to be watching in the future hear your questions, okay? So I see that there's a hand up there. And by the way, I can't know who wants to ask questions unless you raise your hands.
Okay, I had to poke him with my cane because he gets really excited about this part. Because this is what Stuart's all about, is getting people excited to answer questions. I know you got them. So we have both of our presenters up here. Don't forget, Sarah's available to answer any of your questions too. So let's hear about social work, women, pregnancy, whatever you want to ask.
Okay, my name's William, and what I understand about postpartum is that it's a high level of stress to begin with. Since stress does preclude a relapse, wouldn't that be basically why the relapse would be higher? Why the relapse would occur at that time?
I think you're one of the most sensitive men that I've ever heard. Thank you so much for saying that. So that's incredible. It is a really high stress period, and certainly that would be something to think about. And I think as doctors, a lot of times we look right straight to the hormones and the science, but I like that. That's a pretty basic, straightforward thought. So men in the room, if any of your wives are pregnant, please support them and give them no stress. Wake up in the middle of the night with the baby and change all the diapers.
By the way, if anybody has any questions for Sarah on a social work level, she's up here as well to answer any questions you might have. There's a question from this side of the room, but the person was too shy to ask. They want to know when MS Kids Camp is supposed to begin. Do you know anything about that?
So it's actually coming up here towards the end of June. I don't have my phone, so I can't look it up, but Dr. Boster, I think, is actively looking it up right now. We'll let you know in a minute. Did you have a question?
Yes, what is ART? It was on your...
So ART is assistive reproductive technology. So that's any medication, any in vitro fertilization or treatment to help a woman become pregnant more easily than just by natural means.
I have a question up here, and this is for Sarah. If I needed special paperwork done because I want to be off work, what can I expect from you in time-wise? Should I communicate directly with you? Should I do this through the doctor? And can you just tell us a little bit about that process? Because I think a lot of people have issues, questions about paperwork, like related to disability.
Yeah, definitely living with MS. You want to take advantage of any benefits you have at work or any benefits your spouse has at work, whether it be family medical leave or any kind of leave, short-term disability or long-term disability. I think the first step is just making a phone call to the clinic. You can call and talk to the social worker directly, but you don't have to. But just call and say, I want to talk to somebody about this. I'm probably going to recommend an appointment to see your provider so we can take a look at what's going on. When you're filling out forms like that, we have to provide as much specific information as we can on what might make you unable to work. So communication with the clinic is fabulous, and communication with your provider as well.
Great.
You made mention, Dr. Nicholas, about women postmenopausal and the potential for more relapse. I assume that was because of the difference in hormones. How about if somebody's already secondary progressive? Is there more incidence of declining function?
So when I made a mention of women going through menopause who have more symptoms, they aren't specifically having more relapses. As many of you know, probably very early on in your disease, if you've had MS for a while, you probably had more relapses than you're having years and years down the road. Generally, that's what we see in women and men as they age. Interestingly, with women specific to menopause, when they go through menopause and then after, if we survey these women and we say, how are you feeling? How is your MS now compared to prior to menopause? They say that they have an increase in symptoms. That's fatigue, that's cognitive difficulties, even the other symptoms that we see with MS, weakness, numbness. And so really what's been seen in some of these long-term follow-up studies has been a change in physical functioning that's been mentioned. We haven't had any specific studies to cognitive functioning, but that's something that women bring up. There's been a lot of debate over this, whether this is just related to natural aging or whether there is some other process in MS. And I think that MS is both an inflammatory disease and a degenerative disease. And so that's why we need better treatments that are targeting the progressive portion of the disease. And so, you know, the simple answer is that we just don't know yet.
Can I follow up on that question just a moment? Oh, just to follow up, we know that men, I'm looking at all the men here in the room, and you're kind of at the same age us women are. We know that men go through something not quite as dramatic as menopause, but changes as they age. Do we know anything about how their MS changes as they reach that point?
So generally in men, we see that men are more affected by their MS earlier than women. And, you know, we think that that is related to hormones. That being said, for men, men off disease-modifying therapy are reaching disability milestones earlier. So meaning if somebody is requiring, you know, more assistance to do the tasks that they need to do, for some reason for men, that happens earlier. That being said, we are looking at male hormones as well, and there's a lot of evidence for testosterone, and that low testosterone may play a role then more than just sexual dysfunction. that it may play a role in improving energy levels in terms of potentially protecting your disease. But again, this is something that hasn't entirely been panned out yet, but another important topic to look at.
Question here.
As you pointed on the graph, when women are pregnant, the relapses are lower because our hormone levels higher. Is there not a way to synthetically raise our hormone levels so we stay, not that I don't want to feel 9 months pregnant the whole time, but I mean, if we raised our levels, wouldn't that mean that we would have lower incidence throughout our life?
So that's a wonderful idea, and that's the exact idea that many MS specialists had. And they actually designed a clinical trial that was done several years back now, basically looking at women who were on standard of care disease-modifying therapy with glatiramer acetate or Copaxone, who were also placed on estradiol, which is the female pregnancy hormone. Then there was an arm of women who were just on Copaxone. And what they saw when they looked at the 2-year study is that there appeared to be a trend in favor of protecting cognition in that first year. But then when we looked at 2 years out, there was really no difference in terms of relapses and disability progression. But again, I think that more studies need to be looked at. We're also very careful about that because certainly in women, throughout our lifetime, there is a risk of breast cancer and ovarian cancer, endometrial cancers. And so we know that with some of these hormones, they can increase that risk. So that's something that we're very careful about. But I'm with you. That's such a great idea and something that definitely has been looked at and may be looked at in different ways moving forward.
Before the next question, a wise prophet just told me to answer the question about the Camp Connect for children. It's July 23rd and 24th.
It's an annual camp, and it's something that if you connect with the National MS Society, their applications were probably due prior to now. You could still reach out and see if they have any openings, but they've done it annually for as long as I can remember.
Hello.
Sorry about that.
Dr. Nicholas. Hello. My question is about the hormones, and has there been any study between the difference in men and women hormones that may suggest that we have a better chance with the hormone situation?
So women are from Mars and men are from Venus, and so we know that they're very, very different. We do see, as I was starting to talk about, that actually when we look at prognostic factors for MS, we know that women do better, that it's actually more favorable to be a woman with MS. We do think that that's related to estrogen levels. Certainly women with MS have higher levels of estrogen, but I think on the flip side of that, there are a few things that contradict that. We've seen that obesity can contribute to MS, increased risk of MS disease onset, and certainly obese individuals have higher levels of estrogen. So there are lots of things that we're looking at, but there's nothing specific clearly based on male hormones that we think makes their disease slightly more aggressive. And again, this is when we're looking overall as a whole. So there's certainly many men with multiple sclerosis who do amazing, and there are many women who do amazing and vice versa. And so it's just a matter of making sure that currently, until we figure out all those details, that you're following up regularly with your doctor like I know you are, and making sure that your disease is under good control. And Dr. Boster is going to be talking a lot about controlling your MS shortly here.
Got a question back here.
Yes.
Wait. We need a microphone in front of you. Thank you.
You're a star.
Are there like certain birth control pills that are only estrogen based? And does that help?
So you're asking, are there certain birth controls that are only estrogen based, and would that be beneficial in MS? So most birth control pills, and again, I'm not going to lie here, I'm not an OBGYN, and my knowledge of OBGYN is a very, very long time ago. That being said, most pills are a combination estrogen and progesterone, and then there are some progesterone-only pills. I'm not clear on any estrogen only. I would have to ask an OBGYN specialist. That being said, it was interesting this year at the CMSC meeting, which is our large American MS meeting that we were at, there was actually a nice poster, and it was looking at women who have been on birth control and when they were on birth control and came off. And there's been a suggestion that birth control may be protective in terms of delaying MS disease onset. Again, very small study, but something that I think is going to be more interesting to look at moving forward.
Okay, one more question.
Yes, I heard that there's a problem with young girls, that puberty is starting younger and younger. Is there any correlation between early puberty and MS?
So we know that when women go through puberty that there are those changes, and again the changes in the estrogen and progesterone levels. And so I don't know of any single study that has specifically looked particularly at that transition. But that being said, we know that at the time of puberty that's when the risk increases for women to be much more likely than men to have MS. That being said, I think that's a really interesting point. There's just not enough children who develop MS to really be able to look at that, given that it's only about 5%. There's a lot of other reasons why I think MS incidence has increased over the years, many environmental factors, and I think we're also better at diagnosing it.
Sarah,
Okay.
Quick question for Sarah. When people don't know, they may live anywhere in the state of Ohio, can they all contact you, when it concerns like where they could get maybe the help with their medications to get them filled, or maybe something to do with financial resources or anything like that? Can they just speak with you? Can you connect them with somebody in their neighborhood?
I can certainly try. I'm mostly familiar with, central Ohio, but we see folks from all over Ohio and in Kentucky and West Virginia, and so I'm always more than happy to do some research. But I would also recommend, no matter where you live, that you're connected with MS Views and News and the National MS Society, the MS Foundation, the MS Association of America, those agencies that have more national resources. But certainly Ohio Health is always going to be available to help answer questions and provide some guidance.
Great, thank you.
That was wonderful, and I'd like to thank these two speakers again. I know you got your forks in your hands, so however you can clap or show your appreciation.